afternoon, ladies and gentlemen. I must apologize that I was not able to come in person due to medical reasons. I will speak about current and novel treatment in patients with psoriasis. This is my disclosure slide. When we are choosing the best treatment for our patients, we have like basically three domains right now that we are looking at. The first one is the patient, so the patient-related factors like the patient's age, sex, patient history, comorbidities of the patient's compliance, patient expectations, because some patients prefer rapid onset of action of the drug, some prefer like convenient interval of application. We are looking at like the quality of life impact of the disease. Then the second domain is the disease related. So there's like the disease phenotype. We have different subtypes of psoriasis. We have like the plaque psoriasis, pustular psoriasis, acute psoriasis. We have different severity of the disease. For example, in patients with mild psoriasis, we don't need to start the systemics or biologics. We know that we can be quite successful only with the topical treatments. We are looking as well as at disease activity. We should look at the difficult to treat localizations because we know that, for example, scalp psoriasis, nail psoriasis, genital psoriasis is quite hard to treat with a topical or phototherapy or even with some conventional systemic drugs. We should look at the previous treatment and the effect of those previous treatments, as well as the psoriasis comorbidities. The third domain is the treatment-related factors. We have right now many studies, the clinical studies, we have like many registries informations. So we know that the different drugs have different safety profiles, their efficacy is different, their tolerability is sometimes different. Because of the registries, we know the drug survival of the different drugs is different. We know that there is the different of the drug convenience. We have like limited number of oral treatments. Usually the modern ones are the injection treatments. Some treatments are applied every 2 weeks. Some can be applied only once every 3 months. We should as well look at like some of the treatments have as well effect on the comorbidities. There are like right now many studies dealing with this topic. And last but not least is the drug cost, because we are living in reality and sometimes we as well need to look at this. You can see that quite recently there is, in last 20 years, quite like change of the immunotherapy in psoriasis. 1970s, we started with methotrexate, then acitretin, cyclosporin. After 2000, the first generation of TNF-alpha inhibitors, then the first IL-12/23 inhibitor with ustekinumab, first oral treatment with apremilast PDE4 inhibition, and then the two stables of modern psoriasis therapy, the IL-17 inhibitors and recently IL-23 inhibitors. As you can see that with the new treatment options, our treatment goals enhanced. When the biologic started with TNF-alpha, our goal was like getting better psoriasis from the benchmark for at least 50%. So this is the PASI 50. With the generation of IL-17 blockers, we started to be speaking about like at least 75% improvement from the baseline in our patients, the PASI 75, and with the IL-23 blockers, the PASI 90. So you can see that the modern treatments are quite efficacy in our patients. These are the Euro Guidance Psoriasis Guidelines. This is one of the latest you can see for 2020. Usually we should treat patients depending on the severity of the disease. With the moderate disease, we can start with the classical systemic drugs, and in the case of inadequate response, we should move to the biologics. But in case we have severe disease and the chance of the success of the conventional drug is not high, we should directly start with the biologics. Unfortunately, this is not available in many countries, and we have to start always with the several systemic first before we move to the biologics. On this slide, you can see the comparison of effectivity of the PASI response at 1 year is like currently published network meta-analysis as well compared to placebo. You can see the yellowish is the PASI 75 response, the purple is PASI 100% response. You can see that after 1 year, the most efficacious drugs were the IL-23 blockers together with brodalumab, then followed by other IL-17 blockers, then TNF-alphas, and then apremilast. So from this slide, you think that we do not need TNF-alpha drugs anymore. But this is not true. We still use anti-TNF-alpha therapies quite a lot. First of all is that we have long-term, nearly 20 years experience with safety and efficacy with the drugs. We can use them in pregnant and breastfeeding women because of the terzolizumab. Because of the biosimilars, their cost is quite significantly lower, and in some countries we have to start with biosimilars drugs first before we move to the newer therapies. But the most important reason for me is the multiple indications of the anti-TNF-alpha therapies. We know that the patients with psoriasis usually can have other autoimmune diseases like psoriatic arthritis, this is psoriasis, other rheumatic diseases like ankylosing spondylitis, IBDs like Crohn's disease and ulcerative colitis, hidradenitis suppurativa, or other diseases which we can treat with only one drug at once. And now move to the novel treatments. The first one that is available since this year in most of the countries is bimekizumab, which is humanized IgG1 antibody targeting two subunits of IL-17A and F. There are several phase 3 studies, though the data are quite robust. In this study, I choose the phase 3 study where bimekizumab was compared to secukinumab, and you can see like the PASI 75 response was quite similar in patients treated with bimekizumab and secukinumab. But when we start to look at the higher PASI responses, PASI 90 and especially PASI 100, there was like significant difference, like the bimekizumab was more efficacy. So it seems like the bimekizumab will be more successful, especially in these higher PASI rates that we are expecting in our patients. This is as well recently published network meta-analysis. These are the PASI response at week 16. This is including the bimekizumab, which is on the top. The red intervals are for PASI 75. You can see that they are like enhancing with the newer drugs. But the significant difference after the 16 weeks seems to be on the blue, which is PASI 90 response with bimekizumab, which is significantly better, and especially with the PASI 100, the green one. So these data confirm that it seems like the bimekizumab will be quite successful with the rapid onset of action, even in these high PASI rates. The question remains a little bit bimekizumab safety profile. These are the data from pooled results from all phase 2 and phase 3 studies, and you can see that like the common adverse event were the fungal infections, especially the candida infection. The oral candidosis was quite often in patients, but it didn't lead to treatment discontinuation, and usually there were not recidives. The question remains if it will be similar when we start treating, for example, patients with diabetes and other comorbidities. The next drug I want to speak briefly about is mirikizumab, which is IgG4 antibody targeting P19 subunit of IL-23, so it's quite similar to guselkumab and risankizumab. This is from phase 3 study published this year, where patients receive mirikizumab or placebo up to 16 weeks of treatment, and you can see that even after 8 weeks there was like significant better response compared to placebo in all PASI 75, 90 and 100. Here you can see the safety profile of mirikizumab. You can see like in the induction period the adverse events were completely similar to placebo, and in the maintenance period. So it seems this is quite effective and safe drug for use for patients with psoriasis. Unfortunately, because we have like right now many successful treatment in this group, this drug will be not submitted for psoriasis in any region because of the company decision, and it will be like used, for example, in IBD and other indications. So we can see like this group is really crowded right now. Next, quite important drug for us seems to be deucravacitinib, which is TYK2 inhibitor, which is selective allosteric tyrosine kinase 2 inhibitor. It is a new oral treatment, and this is important because TYK2 is responsible for immune mediating signaling of IL-12 and 23, which you heard are like important in psoriasis. The advantage of this TYK2 inhibitor seems like the inhibition of the regulatory domains provides like a high degree of selectivity in treatment, and so there are not so many like adverse events that we are observing usually with other JAK inhibitors like tofacitinib and others. This is from JAAD preprint. You can see the study was submitted right now recently. This is phase 3 study where deucravacitinib was compared to apremilast, so the other available peroral treatment, and placebo, and you can see that both in PASI 75 response and SPGA 01 was significantly higher after 16 weeks of treatments with deucravacitinib compared both to apremilast and to placebo. The effect was like enhancing up to 24 weeks of therapy, and then it was maintained after at least at the 1 year of therapy when the study ended. The question still remains the long-term response beyond 52 weeks of treatment. How will look the treatment interruption on the state of the psoriasis, and if we will have in the future head-to-head trials with other biologics or not, because it will be probably slightly less effective than the most recent biologic drugs. The safety profile in the study was quite good. The adverse events were similar compared to placebo. The most common adverse event in a deucravacitinib group was like the upper respiratory infections and nasopharyngitis, but there was not like higher adverse events of like headache, diarrhea, and nausea, which were quite common in patients treated with apremilast. So this seems like quite convenient and safe treatment for our patients with psoriasis. But finally, we don't have only the systemic drugs, we have as well like the new topical treatments. The first one is tapinarof, which is non-steroidal topical aryl hydrocarbon receptor modulating agent. It modulates the expression of Th17 cytokines, so including IL-17A and F, so the key cytokines as well in psoriasis pathogenesis. These are from phase 3 study, quite robust study, over 1,000 patients in this study, compared 1% cream of tapinarof with placebo. You can see that after the 4 months of therapy, the PGA 0 to 1 response was significantly higher in patients in both studies using the tapinarof compared only to vehicle. But as you can see on the right picture, there were some adverse outcomes in these patients treated with tapinarof, like including folliculitis, contact dermatitis, and systemic ones like headache in our patients. The next drug is roflumilast, which is as well topical therapy, which is a selective, highly potent PDE4 inhibitor. This is the data for as well the phase 3 study with 0.3% cream vs placebo. You can see the EGA success like EGA 01 compared as well to vehicle. You can see that there was significant difference even after 2 weeks of treatment, and the treatment was getting better up to 8 weeks of therapy, where the EGA success was observed in more than 40% patients treated with roflumilast compared only like to 6% patients treated with vehicle. On the right side, you can see from these two studies like the adverse events in these patients. There were not many of them, but compared to vehicle, you can see that in patients treated with roflumilast, in some the headache appeared, diarrhea was quite common in the patients, not observed in placebo. So that may be the limitation of this new nice topical drug. So you saw me and heard me that there are many new drugs that we have. Why we need new drugs? Because these drugs are quite effective, but in some patients we still don't achieve like the significant improvement of psoriasis. the current treatments are not effective for all types of psoriasis, like the pustular psoriasis. The response is limited in some localizations, like the scalp psoriasis, and the injection therapy is sometimes a problem for some patients. Fortunately, we have many studies. I checked clinical trials a few days ago. There is over 140 phase 2 and phase 3 studies with new drugs dealing with psoriasis. And here on the table you can see like there are as well the new mechanisms of actions which are like in phase 2. So very probably we will have as well new nice drugs for our patients with psoriasis. Thank you for your attention and enjoy the rest of the symposia.